For this lecture, we're going to talk about patients with hepatic disorders. So these are disorders and problems with the liver. Okay, so we're going to start with a little overview of the liver and its function. So the liver is the largest internal organ, and it's one of the most vital organs in the body. This is located in the right upper quadrant area underneath that diaphragm, and it kind of extends across the midline. This is a highly vascular organ, so it's full of blood and vessels and receives about 25 to 30% of our cardiac output. It has a two-part blood supply, so it has the hepatic artery that runs through it and the portal vein. So the hepatic artery supplies that oxygenated blood to the liver, and that portal vein carries nutrients and things like that from the stomach, the intestine, and the spleen. So about 75% of the blood supply is received from that portal vein. Now, since the liver filters everything that's absorbed by the GI tract before it reaches the system, this is the first pass of metabolic metabolism. So some of our main functions of the liver. So first thing is it is the metabolic powerhouse. So this is where most of our metabolism comes from, and it's responsible for metabolism of carbohydrates, proteins, and lipids. So it breaks down those into usable energy for our body. The liver also acts as a storage unit, so it stores glycogen, iron, and copper, and helps as a reserve for fat-soluble vitamins. So the fat-soluble vitamins are A, D, E, and K, and vitamin B12. So it helps to store those and helps release it into the bloodstream as needed. So we'll talk a little bit about some of those deficiencies as well. It also helps with bile formation and excretion. So the liver has bile salts and cholesterol and bilirubin and things like that that is excreted so that the digestion can occur. So if fat digestion is impaired, this leads to what we see with our fatty stools, that's steatorrhea, and can lead to fat-soluble vitamin deficiency if those areas are blocked. The liver also processes bilirubin, which is that byproduct of broken down red blood cells. So if our liver is not processing bilirubin correctly, we'll have an accumulation of that, and it can lead to jaundice that we talked about, which is the yellowing of the skin, dark urine, and clay-colored stools. So we would want to look at that for bilirubin metabolism. And then our liver also detoxifies our blood. So it helps detoxify things like toxins, drugs, alcohol, and something called ammonia. So ammonia is going to be something that's going to come into play when we talk about disorders of the liver that you should be aware of and how the liver works to clear ammonia from our blood level. The liver takes that ammonia and converts it to urea, and urea is able to be excreted by the kidneys. When we have that impaired detoxification, it's going to lead to something called hepatic encephalopathy, and we're going to talk about that later in this lecture, but that's something to be aware of related to the liver detoxification process. The liver also plays a vital importance or an importance for our immune system and our immune function. So we want to be aware that the liver contains cells that destroy bacteria. It destroys old, destroyed red blood cells and can also help destroy foreign substances. So it helps to do kind of a regulatory action on the immune system to reduce systemic infection. Our liver also helps with synthesizing plasma proteins and clotting factors. So the liver helps to produce albumin, which is really important for maintaining oncotic pressure, which you're going to learn a lot more about albumin and how we utilize it for blood pressure control and things like that in complex care. But just know that it produces albumin, which helps with blood pressure and pressure of the fluid inside of our vessels. and also helps to produce clotting factors. So it's really important for us to be able to have normal coagulation. So for our patients with liver failure, they're going to have things like bruising, prolonged bleeding, prolonged PT-INR levels, and decreased fibrogen and prothrombin in normal coagulation. So those are some of the functions to be aware of when we're looking at our lecture here, and just understand how this impacts our body and our system when we don't have normal functioning. Okay, so we're going to talk a little bit about the pathophysiology of hepatic dysfunction. So this is when our liver is not functioning correctly. This can be due to a couple different conditions or problems that cause the liver to not be able to perform its metabolic, synthetic, and excretory functions. So because it's responsible for a lot of different processes, even partial loss of function can have a whole system-wide effect. So when the liver fails, usually every system feels the impact of it. So we have two main categories of hepatic dysfunction to talk about. One is acute hepatic dysfunction. This is sudden injury to those liver cells. Examples of this or causes would be things like a viral infection, like acute viral hepatitis, drug-induced liver injury, so somebody who maybe overdoses on acetaminophen, or ischemic hepatitis due to a lack of blood flow from hemorrhaging. Then we have our chronic hepatic dysfunction. This is kind of a progressive, worsening destruction of the liver cells and leads to a scarring or fibrosis over time of that liver. So what we have or what we see in chronic hepatic dysfunction are patients with cirrhosis, either related to alcoholic cirrhosis or hepatitis cirrhosis. This is a scarring and buildup of scar tissue on that liver, so it's not able to function correctly. Then we also have a side thing that we don't see as commonly, but it's non-alcoholic fatty liver disease. Typically, though, what we see is patients who have a high level of alcohol intake or have had drug-induced liver injury that we'll see problems with, as well as hepatitis. So we're going to talk about those main disorders in this lecture. So once there's injuries to those hepatocytes or liver cells, inflammatory process begins, and the cells start to die off, which causes a hepatocyte necrosis. So those cells start to atrophy and die off. Then what happens is collagen is deposited into that space of dead tissue, and it's replaced with scar tissue. So that liver starts to build up scar tissue and becomes non-functional. So we have a loss of complete hepatic function. Now, some of the cells can regenerate, but once you lose a certain percentage of your function and a certain amount of liver tissue, that liver is going to fail being productive and doing what it needs to do. So as functional hepatocytes are replaced by that fibrotic tissue or that scar tissue, detoxification can decline, which leads to an increase of ammonia, which leads to confusion, and we'll talk about that, hepatic encephalopathy. Protein synthesis decreases, so we start to have low albumin levels, poor clotting factors, and then bile secretion is impaired. So that leads to bilirubin retention and leads to that jaundice or yellowing color. We can also have vascular changes that leads to portal hypertension. So that's hypertension in that portal vein, and that can cause blood to back up into the spleen, the stomach, and the esophagus. So then what we're seeing are things like splenomegaly, which is an enlarged spleen, esophageal varices, which are kind of varicose veins in the esophagus, which can lead to bleeding, and that ascites, which is that big distended abdomen. We'll talk a little bit about those. Some of those, though, you'll go into depth in complex care and really understand how they treat that. For our systemic effects, if our liver is not working, we can have changes with metabolic processes, things like, glucose intolerance, hypoglycemia. We can have neurological changes. So this is especially important related to that elevated ammonia level. If that ammonia level is elevated, it leads to confusion, neurological changes, and this is related to hepatic encephalopathy, and we're going to talk about that in this lecture. We'll have hematologic issues. So again, I said prolonged bleeding due to decreased clotting factors. Patients may have anemia or thrombocytopenia, which we talked about in our hematology lecture. Endocrine systems will have changes as well. So patients may have menstrual irregularities due to a hormone buildup in the blood. And then we'll have increased risk for infection due to the damage of the immune system from the decreased cleaner cells that we have in our liver. For your patients, you want to think about what could be impaired related to the liver function to tie the subjective and objective data findings that you're going to see. So a lot of our patients with liver failure, they're going to come in complaining of weakness, fatigue. They may have unexplained weight loss or anorexia. They're definitely going to have abdominal pain, especially in that right upper quadrant, and may have signs of bloating. So a little bit of that, distended abdomen. They may have nausea or vomiting as well. Due to the bile salt accumulation of the liver when it fails, they may also have pruritus. So that is usually an itching on their abdomen. And a lot of liver failure patients, they'll have that distended ascites abdomen, and they'll have itching all over their abdomen. So that's another sign of liver failure. Patients will also have or report or may report a history of drug use, like medications, Tylenol, or hepatotoxic medications. They may also report a use of excessive alcohol. So that's usually your two main causes that you'll see is excessive alcohol consumption and medication overdose. Patients may also have a past history exposure of hepatitis. So we'll talk about the different types of hepatitis and how they can be exposed, but they may also have a family history of it as well. So these are some of your subjective findings that you'll get told by your patient that would explain their diagnosis of hepatic failure. Okay, for your objective or observed assessment data, some of the main things, trigger words or common cues that you'll see with liver failure is going to be that jaundice. So that's that yellowing of the skin and sclera that's caused by the increased amount of bilirubin, which is caused by an overload of those broken down blood vessels. So the body's not able to clean that out of the system. So that jaundice builds up over time and can get pretty severe, kind of like the picture we saw on the last lecture with the elderly person with the jaundice. It can be yellowing skin, sclera. You can see it kind of on the mucous membranes. It's a little bit yellow tinted as well. They may also have ascites, so that's that large abdomen that's distended and rounded. This can be due to a buildup of fluid on the body, but it can also be due to an increased liver size or spleen size as well. So we talked about that on our previous lecture as well. We'll definitely probably see some bruising, frequent bruising, and what's called petechiae. That is a pinpoint blood rash. So it's smooth, but it looks like little tiny broken capillaries, and that's what it is. So little tiny broken capillaries under the skin. That's called petechiae. And that's due to that absence of clotting factors. So patients will have increased risk for bleeding, bruising, and a petechial rash. Then we may see spider angiomas and palmar erythema. So this is palmar erythema is redness on the palms and the soles of the feet, and spider angiomas are kind of little spidery looking capillaries, usually on their nose and their cheek area, and that's due to the decrease of clotting factors as well. And then asterixis. So asterixis is a common one, and we're going to talk about this again when we talk about our hepatic encephalopathy. But this is a common sign of later hepatic encephalopathy when that high elevation of ammonia levels has caused brain problems, so neurological problems. So asterixis is hand flapping. So if you have your patient who has liver failure hold their hands out in front of them, kind of like a zombie with their fingertips up, you'll notice that their hands kind of flap back and forth and in a tremor fashion. And so that's called asterixis. That's very common for your liver failure, and that would be a sign and symptom I would think to kind of tie with this lecture for sure. They're also going to have that confusion level, and that's due to that increased ammonia level as well. We'll talk about that as well in depth a little bit later. Okay, so we're going to look at some laboratory findings related to our hepatic dysfunction. One that you need to know, and bold it, highlight it, put it in your notes, are the liver enzymes. So that's going to be AST and ALT. So both of these are liver enzymes that show an increase of liver failure. So AST stands for aspartate aminotransferase. Our normal level is about 10 to 40, and so this is found in that liver tissue. An increase of AST is what occurs with liver cell injury or that necrosis that's occurring from drug toxicity or hepatitis or things like that. We usually see a higher AST level in patients with alcoholic liver disease. So if they have a super high AST, chances are they'll be an alcoholic. Your other one, ALT, is for alanine aminotransferase. Most of nurses don't know the fancy words, but they know AST and ALT. They know those are the liver function tests. So that's really important for you to know. This is specific to the liver. This is a sensitive marker that shows hepatocellular injury as well. So our high levels of ALT are common in acute hepatitis, especially things like drug-induced injuries or that fatty liver, okay? So ALT is more liver specific than AST, but they both go hand in hand when you're looking at your liver function. Then we have our ALP, our alkaline phosphatase. This normal value is 40 to 120 and is typically found in that bile duct tissue. So when we have an increase of the ALP, this usually is from an obstruction of the biliary duct, can also be in correlation with the gallstones from the gallbladder. So your gallbladder and your liver kind of go hand in hand. If one fails, the other one starts failing and vice versa. So we'll look at an ALP level to see if there's any damage or any correlation with the gallbladder as well. Then we have our bilirubin level. So we talked about that. Bilirubin is that breakdown of red blood cells. So if we have a high level of bilirubin, this usually is a correlation with our clinical findings like jaundice, dark urine, and clay-colored stools, and that pruritus, that itching of the abdomen. Then we have our PT and INR levels. So these are our coagulation levels. Normal PT is usually about 11 to 13. And so we really want to assess this in our liver patients to see if they have enough synthesization or creation of those clotting factors. If you have a higher PT or a longer PT, that means it takes longer for your blood to clot, and so you're at higher risk for bleeding bleeding risk. Now, a vitamin K deficiency or a biliary obstruction can also cause a prolonged PT, but for the most part, we see that a lot in our liver patients. So if we're doing any liver biopsies or surgeries or anything like that, we always want to check PT and INR before we do that, so we don't cause them to bleed out. Then we're going to talk about our ammonia. So I've said it a couple times. This is a really important lab level to understand with our liver failure. But when we're looking at ammonia level, our normal level is about 15 to 45. And this is a byproduct of protein metabolism. So usually our liver converts it to urea and it's passed over to the kidneys and we pee it out. And that's fine. Our body normally functions with that. But when our liver stops converting that to urea, the ammonia level increases in our blood. And that ammonia level causes our blood to become toxic, essentially. And so it starts affecting all of our body systems. We start having what's called hepatic encephalopathy. And that means our hepatic or liver has caused a confusion or encephalopathy of our brain. So for our patients, they're going to have severe confusion, irritability, and they're going to have that asterixis or flapping hand tremor that is common for these patients. For our treatment for that, we're going to talk about it a little more in depth on a different slide, but we're going to give medication that is used to lower that ammonia level. It's called lactulose, and a medication called rifaximin. So that's going to help with decreasing that ammonia level. That's pretty much the lab levels I want you guys to know. So just be really aware of AST, ALT, bilirubin, your ALP, albumin, and ammonia. Oh, and PT-INR. So basically all the ones on the screen, you need to know what they are and understand how they tie in with our liver function. Okay, so some of the diagnostic tests that we use are going to be that ultrasound or a CT MRI. And what we do here is we look at the size of the liver, we look at any blood flow, we look at dilation of those portal veins, and we look at ascites to see if there's fluid buildup on the abdomen. We may utilize a liver biopsy. This kind of confirms that diagnosis of those cells being atrophied or necrosed. And we'll talk a little bit about liver biopsy because there's a couple nursing interventions that we need to do for that. But for the most part, with anything liver biopsy or liver surgery or anything like that, your main thing is bleeding because it's so vasculature, right? It's got so many vessels and so much blood coming to it. We may do a paracentesis. So this is a removal of fluid from the abdomen, that lining of the abdomen, and we look at removing that fluid from it. Now, there's going to be some nursing considerations for that. It's a giant needle that we put in their abdomen and we remove fluid. So think about bleeding, especially if they have a low PT or a high PT-INR. So we have higher risk for bleeding. And make sure that we don't remove too much fluid, which causes a fluid volume shift, can cause low blood pressure. And we also want to make sure that that big long needle, we don't nick something, right? So internal bleeding would be something we would watch for as well. Then we use our hepatitis markers. So the ALT, AST, ALP, all of those lab values that we talked about on the previous slide. All of these kind of paint a good picture and look at liver failure along with your patient's subjective and objective findings. Okay, so we'll talk a little bit about a liver biopsy. So pre-procedure, right? Pre-op, we want to make sure we get consent, we educate the patient, we check vitals, make sure they're stable. We want to make sure we check coagulation studies and make sure that they don't have any bleeding risks. Their lab levels are okay, considering we're going to take a giant needle and put it right into their liver. And you can see that on the slide there. It's got the liver biopsy. It takes, the needle is hollow, so it takes a full little like sliver of the liver. So we definitely have some bleeding risks. We want to make sure they're NPO, right? Nothing to eat or drink before surgeries, the usual pre-op stuff that we've talked about in our lectures before. Post-op, it's really important though that they position themselves laying on the right side. That's going to help to put some pressure on the liver and the area of biopsy. Maybe put a little pillow or a rolled towel under there to kind of put some pressure on the abdomen area so that we prevent bleeding. We want to monitor vital signs and the site for bleeding. So look for bruising, look for abdomen distension. We're going to check to make sure their blood pressure is not dropping, their heart rate's not increasing, and those kinds of things for monitoring for internal bleeding. We want to educate them to avoid heavy lifting for about a week or so after the procedure, just to make sure that they don't put any pressure on that site and pop the clot. So that's really important information for your liver biopsy patients. I think we talked about jaundice for the most part. You guys know what to look for, you know how to assess it, and you know what it's from. So I'll just put this slide here. It's just a recap. Okay, and again, I kind of feel like we've talked about ascites. This is that buildup of that fluid, can cause some shortness of breath, abdominal distension. So really, we want to make sure that we are monitoring that, measuring abdominal girth, doing that paracentesis, needle removal if necessary, and we oftentimes will use a diuretic as well to remove some of the fluid off of the stomach. Okay, so we are going to talk about hepatitis. This is just a general overview. This is just general inflammation of the liver. So it's an inflammatory condition that's usually caused by viral infections like the hepatitis virus, which we'll talk about, alcohol use, the toxins, drug overdose, autoimmune reactions where our body attacks its own liver, or metabolic disorders. So all of these problems lead to that inflammatory process to start injuring those hepatocellular cells, so those liver cells. They start to become injured, broken down, and can lead to that necrosis. That leads to that fibrosis or scarring of the liver, and so it can actually lead to cirrhosis of the liver, which we'll talk about later. For our hepatitis, though, initially there is that viral or toxic injury. It leads to that inflammatory process to occur, and that inflammatory process leads to the necrosis of those liver cells. Now, there are a couple different types of hepatitis to be aware of, and NCLEX tests on this a lot to see if you know transmission routes and kind of the source of hepatitis. So it's really important to understand the different levels, how they get the different levels of hepatitis, and education on preventing these. So we're going to go through them. So hepatitis A is a fecal oral transmission. That means it's passed out of the body by fecal, right? Somebody poops out hepatitis A, and then it gets transmitted to another person via oral route. So we see this a lot with contaminated food and water. So a lot of times this is in countries or places with really poor hygiene. They don't have good, clean water. They're not washing their hands. This can be transmitted in restaurants and things like that. An individual goes to the bathroom, has a bowel movement, doesn't wash their hands, and they go cook food. So especially food that's not, cooked in heat to kill off the virus. So hepatitis A is that fecal oral transmitted route, contaminated food and water, poor hygiene. There is a vaccine for it and can be prevented, most importantly, by good hand hygiene. Then we have hepatitis B. So B stands for blood and body fluids. This is typically transmitted through sexual contact with infected body fluids or needle sharing. We see this a lot with patients that do, IV drug use and they share needles. Sexual intercourse and things like that can be a high risk for hepatitis B. There is a vaccine for hepatitis B. We typically give this to babies just so there's no blood exposure, when they're being born and everything. But standard precautions like gloving and clean needles and, sexual practices, utilizing condoms and things like that helps to prevent hepatitis B. Then we have hepatitis C. So C is usually from blood and body fluids as well. This one is definitely from sharing of needles. And previous to 1992, we saw it a lot with blood transfusions, but now it's lower risk for blood transfusions since we're able to screen for this. Hepatitis C has no vaccine, so we really want to make sure to screen our high-risk patients, educate on safe sex practices, making sure they don't share needles, and they, really keep a good hygiene. Then we have hepatitis D. So hepatitis D is actually a super infection or a co-infection with hepatitis B. So they kind of go hand in hand. Hepatitis B vaccine can actually help to prevent hepatitis D. So we educate on making sure that they take their vaccines as well. So hepatitis D is transmitted through blood and body fluids, and it's kind of a super infection related to hepatitis B. So B and D go together. And then we have hepatitis E. So hepatitis E is a fecal oral transmission as well. This is found in contaminated water. And so most of our education for prevention has to do with hand hygiene, sanitation, and making sure that we have clean water. So one little memory trick: hepatitis A and E, if it has a vowel, it comes from the bowel, so that's your fecal oral transmission. B, C, and D come from the blood. When we look at hepatitis, we also have some clinical manifestations. So during that initial prodromal phase, patients may just kind of have a feeling of fatigue or malaise. They might have a little bit of right upper quadrant discomfort. They're not really feeling good, but they don't really feel like anything's hugely wrong. You kind of just feel like you have a flu, right? So you're nauseous, vomiting. This is when the most infectious period is because individuals don't really know there's a huge problem. They just think they're kind of under the weather. During that jaundice phase or the icteric phase, this is where that jaundice starts to build up, and patients can start seeing that hepatomegaly and right upper quadrant tenderness really kind of more painful. They might start having that pruritus or itching in their skin, and they'll have a change in their urine and stool. So they'll start having dark urine and dark stool. Then they might have all of these things go away. So this is called the recovery phase. This is where those symptoms sometimes subside, appetite returns. They kind of feel a little bit better, but that liver is going to remain enlarged for weeks. And then after that, our liver starts to fully kind of become dysfunctional after that. And then we'll start to see all of those really, chronic problems related to chronic hepatitis. So for our nursing management for acute hepatitis, we want to make sure that we promote rest. This helps with hepatic healing. We want to give a high calorie, moderate protein, low fat diet, making sure the patient eats small, frequent meals. We really want to maintain hydration and have them avoid the cause of that liver failure. So if they're a drinker, they got to stop drinking. We got to let that liver try to repair itself or heal. We want to avoid hepatotoxic drugs, so things like acetaminophen are one of the really common ones, and maybe give them some medications for nausea and for their abdominal pain and things like that. During acute hepatitis phases, we really want to make sure that we teach good prevention for transmission, hand hygiene, safe sex, and needle precautions. For our chronic hepatitis patients, they would be given antiviral medications. These are usually common for our the hepatitis B vaccine or hepatitis B and hepatitis C, excuse me. So for our hepatitis B, usually we give antiviral medications like tenofovir or entecavir. For hepatitis C, usually we use direct acting antivirals. So that's going to be things like sofosbuvir. Good grief. So just know antiviral medications. You don't have to be an expert on the antivirals. One thing for antiviral medications that are nice to know or good to know or important, it'll help you with your medications, is anything ending in VIR is usually an antiviral medication. So VIR, viral medication. But antiviral medications are given for chronic hepatitis. We then want to make sure we monitor for complications. So we talked about that liver cirrhosis, so that worsening scarring of the liver, hepatic encephalopathy, and those kinds of things. We can also monitor for portal hypertension, so that's hypertension or high blood pressure related to the inflammation or blockage of that portal vein. Okay, so we're going to talk about liver cirrhosis. So liver cirrhosis is when that liver becomes so scarred and damaged that we can't reverse that liver disease. Those cells are not going to regenerate. This leads to a lot of the same cues as liver failure. So your patients are going to be fatigued, right upper quadrant dysfunction or discomfort. They're going to have that ascites. They're going to definitely have jaundice. They may also have things like confusion, asterixis. Our AST and ALT labs are going to be elevated. So we're going to really just find full dysfunction of that liver. For our patients, some of the main things we're going to want to do is making sure that we decrease use of alcohol, again, making sure that we decrease the cause of that liver failure. We're going to make sure that we manage fluid volume excess and ascites. So they're going to get diuretics like furosemide or spironolactone. They're going to get a low sodium diet because remember, fluid follows salt. So low sodium diet. We're going to watch for bleeding, okay? So making sure that we avoid bleeding, teach them bleeding precautions and risks. We're going to manage that high ammonia level. So they're going to have super high ammonia levels because that liver is just not functioning at all anymore. So what we're going to give them is a medication called lactulose. Now, lactulose binds to the ammonia in the blood and causes it to exit the body, and it exits the body in our fecal matter. So your patients with lactulose, they're going to be pooping a ton, and we want them to do that. They're going to have frequent bowel movements, and it's going to be a diarrhea type of a stool. But we want them to do that because we've got to lower that ammonia level. We also are going to give rifaximin. This reduces ammonia producing bacteria. So they're going to give both of those medications to help prevent that hepatic encephalopathy. And we're going to talk about that more in the next couple slides. We also want to make sure that we give vitamin supplements, A, D, E, K, and B12, because our liver no longer is making those and not able to kind of help promote those. High calorie, moderate protein diets for our patients, unless they have encephalopathy, which we're going to talk about. Making sure to prevent infection and promote skin integrity as well. So these are all of, quite a bit of interventions that we have for our liver cirrhosis patients. But for the most part, we're looking for worsening symptoms and worsening complications that could occur from that liver not functioning at all. So hepatitis is the initial stuff. Liver cirrhosis occurs. And then after that, we move into our hepatic encephalopathy, and that's a late occurrence that we're going to talk about now. Okay, so now we're going to talk about hepatic encephalopathy. So hepatic encephalopathy is going to be due to that increased high levels of ammonia. And this is usually found in patients who have liver cirrhosis. This is a kind of a life-threatening complication. It can lead to coma and can lead to death, but it is reversible. So the good news is we can catch it early, we can prevent it, and we can keep our patients safe. So hepatic encephalopathy is a neuro disorder that's caused by liver dysfunction and that accumulation of the toxic ammonia that builds up in the blood. So our liver's not able to get rid of that ammonia level and other waste products, and so they cross the blood-brain barrier and lead to that altered mental status. It also leads to motor disturbances and can lead to a coma and death if we don't catch it early. So for our patients, what we want to do is we want to watch for our clinical manifestations of hepatic encephalopathy. Now, most of these look at mentation, confusion, and mental changes. So we want to catch that early. These patients may have things like slurred speech, impaired judgment. They'll be really confused. They're trying to crawl out of bed all the time. They have those tremors or that astrixis, which is the flapping of the hands when they hold their arms out. They're going to have what's called fetor hepaticus. That's a musty, sweet, odorous breath. So it smells like liver breath. They may have an inability to follow commands. They may be sleeping, super lethargic, not able to get up, not really able to pay attention to what you're saying. So we really want to make sure we assess that early. So what we're going to do is we're going to draw a level, serum level ammonia. So we're going to draw their ammonia levels, and we're going to look at making sure that that's not too high. Normal is 15 to 45. So sometimes with our our liver failure patients, what we'll see for high ammonias is in the 200s, 300s, 400s. These are really, really high levels of ammonia, and ammonia is toxic in our blood, okay? So we really want to make sure to catch that early. We're going to look at AST and ALT and bilirubin levels. That's going to be super elevated as well. So those liver function tests are going to be super high. We're going to have prolonged PT and INR. So our clotting factors are going to be in the toilet. So these patients are at super high risk for bleeding. So again, our treatment for this, once we assess that they have hepatic encephalopathy, we're going to give that lactulose medication. Now it can be given via oral liquid. So if they're alert and oriented enough to be able to drink a medication, you're going to give it that way. If they're not alert and oriented enough, they're going to give it through an enema. So they'll do a lactulose enema. that's going to cause them to poop. And we want them to poop about 3 to 4 times per day. And it should be that soft, liquidy diarrhea. That means that ammonia level is coming out of their body. While we're doing this, though, think about that. You want to monitor for dehydration. So we want to hydrate them and we want to watch electrolytes. We also are going to give an antibiotic called rifaximin. So this is an antibiotic that helps to decrease ammonia producing intestinal bacteria. This is usually given at the same time as lactulose. So we're going to watch for signs and symptoms of allergic reaction for that antibiotic. We may give medications like neomycin or metronidazole. These are usually given less frequently than the rifaximin, but if somebody has a rifaximin allergy or can't take it, then they will use these as well. Some patients, they will refuse their lactulose because they don't like to have diarrhea, right? It's not a side effect though. This is how we're going to get that ammonia to leave the body. So we need to do really good education for our patients, teach them how to take their lactulose, teach them to take it every day on time to keep those ammonia levels low. We also want to watch for electrolyte imbalances, make sure that we reduce the use of sedatives and narcotics and things like that. If they're already, kind of altered with their mentation, we want to make sure that we monitor that neurological status frequently, maintain a safe environment, make sure that they have help with their ADLs and things like that. These patients are super, super confused and they are not safe. And NCLEX loves to test on safety of patients. So we want to assess them, get ammonia levels under control, and keep them safe throughout their treatment. Okay, so making sure that we have a nutrition assessment for our patients with liver disease, making sure that they have high calorie, moderate protein levels of food, a low sodium diet, unless that encephalopathy is present and they may have low sodium to begin with, but making sure that they have fat soluble vitamins given as well. So A, D, E, K, and B12. We talked about nutrition throughout the lecture, so I think we're covered on this slide. Okay, and then just making sure our patients understand their education. So once we fix their ammonia levels, we send them home. We need to educate on that medication adherence, understanding bleeding risks, understanding importance of vaccines for hepatitis A and B, making sure that they take their ammonia medication, that lactulose, making sure that they stay away from those hepatic toxic drugs and alcohol use.